In this video, we present the case of a 74-year-old female without a significant medical history who suffered a thunderclap headache and presented to our emergency care unit in a pre-comatose state. The patient underwent a head CT scan and angiography that documented a fissure 4 subarachnoidal hemorrhage with tetraventricular inundation and right small intraparenchymal hematoma consequent to a right middle cerebral artery aneurysm rupture. Based on admission CT, we calculated a Grave score of 10. The ruptured aneurysm underwent immediate and successful immobilization. Therefore, it was then decided to clean the ventricular system endoscopically. Neuroendoscopic treatment has become the gold standard in the case of massive intraventricular hemorrhage in our unit. By direct aspiration of blood clots, including the foramen of Monroe, the aqueduct of Sylvius, and the fourth ventricle outlets, we can promptly resolve intracranial hypertension and acute ventricular dilation. The maneuver aims to increase cerebral perfusion and may help in minimizing the chance of late hydrocephalus and shunt dependency. Overall, the technique simplifies the treatment paradigm for intraventricular hemorrhage. Compared to the rigid endoscope, the flexible endoscope allows us to reach the entire ventricular system down to the fourth ventricle. The flexible distal tip helps to follow and cross the ventricular system angles and easily navigate through the foramen of Monroe and Sylvius aqueduct to gain access to the fourth ventricle. The endoscope is fixed to a holder and a 20 milliliter syringe is added to the irrigation channel through a 3-way tap to allow for suction and more aggressive irrigation. The procedure always requires 2 operators, one for the endoscope control and the other one for irrigation and aspiration of blood clots through the syringe. Here we propose our freehand technique, maneuvering a flexible endoscope in which we use the working channel as an aspirator. At the same time, the blood clots are mobilized and sucked by intermittent irrigation with Ringer lactate solution and aspiration maneuvers. The surgeons must bear in mind that the rinsing aspiration maneuver is done alternatively during the whole procedure. Rinsing is done to mobilize the blood clots to uncover the ventricular system anatomy. The syrinx is used to perform more aggressive irrigation to free the clots in case of firm adhesion. The blood clots have a black or reddish aspect and move freely under the continuous stream of saline solution. The aspiration should be stopped when the whitish appearance of the ependema is seen. The operator has to be aware of and balance the quantity of saline solution injected and CSF extracted. The whole procedure should be focused on cleaning the third and fourth ventricles without aiming for a complete cleaning of the lateral ventricles. Indeed, the clots in the third and fourth ventricles are usually more fragile and easier to aspirate, while they are more tenaciously adherent in the lateral ventricles. The first phase of the operation consists of freeing the peel away from any possible blood clots. The endoscope is then introduced into the peel away channel to reach the blood clots, which are removed by an alternating maneuver of aspiration and irrigation throughout the endoscopic working channel. When the tip of the endoscope comes into contact with a clot, the visualization in the camera is reddish or dark. This is the moment for aspiration. On the other hand, when we visualize a whitish background on the camera, It means that the tip of the endoscope is close to the ependema, which is the signal to the surgeon to interrupt the aspiration maneuver. The cleaning of the lateral ventricles is perhaps the most challenging phase of the operation. The surgeon should seek out anatomical landmarks for orientation. Here we can see the vein of the septum pellucidum. The blood should be aspirated starting from the inferior part of the ventricle. As always, when visualization is dark or reddish, it is safe to aspirate. During aspiration, the surgeon will feel a gurgling sensation throughout the endoscope. Clots need to be aspirated, alternatively with irrigation, until the ependema is visualized clearly. Here we see the Monroe foramen occupied by small clots. After removing the clots from the Monroe foramen, we move the endoscope towards the floor of the third ventricle. The infundibulum, as well as the optic chiasm and mammillary bodies, are visible. Then the endoscope is moved towards the posterior part of the third ventricle in order to visualize the aqueduct entrance occupied by a clot. The third and last phase is the cleaning of the fourth ventricle. The endoscope is gently passed through the oditis of the aqueduct of the fourth ventricle, and the clots are aspirated. Here it is important to pay attention to avoid over-irrigation, which may cause bradycardia. Here we can clearly see the median eminence, the Magendie, the choroidal plexus, and the Luschka recess. Eventually, we carefully extract the endoscope, checking to make sure that we have not caused damage to the walls of the ventricular system. The most common cause of intraventricular hemorrhage is spontaneous intracranial bleeding and bleeding from the rupture of aneurysms or arteriovenosus malformations. Intracranial blood has multiple dangerous effects on the brain, such as CSF circulation impairment, risk of intracranial hypertension, and acute or delayed hydrocephalus. Management of massive intraventricular hemorrhage usually requires traditional surgical approaches, such as external ventricular drainage placement for intracranial pressure control or intraventricular fibrinolysis to dissolve the blood clots. Despite the best medical and surgical management, mortality remains high, with only 38 to 50% of patients surviving the event. Neuroendoscopy may offer some advantages over more traditional surgical approaches for the treatment of such life-threatening occurrences. Post-operative head CT scan documented the satisfactory evacuation of blood from the whole ventricular system. The newly calculated Graves score was 2. While the ventricles were not completely evacuated, the third and fourth ventricles were adequately cleaned without visible obstruction to CSF circulation. The patient was discharged to the rehabilitation department 10 days after the procedure without requiring permanent CSF shunts.